where there are not so many diagnostic area services available. So these are fluid analysis is what we're going to look at. And the diagnostic modalities that we're going to look at are basically what we use in the routine lab, and very, very applicable to every one of us, as long as you're practicing in medical breast sciences. This is something that you can be able to do. And I know that we've been doing some aspects of it, but today we're going to comprehensively discuss around body fluids analysis. So that's the topic, and that's those are my details. And we're going to look at the objectives of this presentation this afternoon, and we're going to define some few terms. All right, we're going to add some few terms as related to body fluid analysis. Then look at how we can be able to collect the body fluids. And then also describe the diagnostic approaches to the three categories of fluids that I have highlighted in this section, excluding urine analysis, excluding other blood analysis, excluding semen analysis. Those are other fluids that maybe have been tackled by some other panelists in the course of these presentations. So the fluids are distributed, as you can see in this particular image here. We can see where the CSF is, we can see where the pericardial fluid is, we can see where the peritoneal fluid is, we can see where of course, pleural fluid, and then we can see where the peritoneal fluid is, and the synovial fluids over there. So all those are the fluids we're going to look at in this particular discussion. Now, on defining some few terms, body fluids are just lubricating liquids found within body cavities. And just as the definition is saying, they are actually meant to lubricate and cushion the organs that they align, that they, and surround. Then examples include the pleural fluids around the lungs, peritoneal fluids around the abdomen, pericardial fluids around the heart, synovial fluids around the joints, and then cerebrospinal fluids around the central nervous system, all the way from the brain and the spinal cord. And effusion is an increase in the volume of these fluids. So if you hear the word effusion, it simply means that these fluids are there, yes, but in increased volumes, like that. Now, brief mention on body fluids. We know that the total amount of fluids in the human body is approximately 70% of your body weight, right? And that this fluid is divided into intracellular fluid and extracellular, and intracellular is more. Extracellular is around 45% of the body water, and then intracellular fluid is around 55% of the body water. And they're composed in this particular order. We have organic substances like glucose, amino acids, fatty acids, and hormones and enzymes. There are also inorganic substances such as sodium, potassium, calcium, magnesium, chloride, and phosphate. All those are components of these body fluids. And as you can see here, we have a cell here that is outside the body circulation. This is the ordinary circulation. This is the blood vessel. But these cells are outside the circulation. But there is a fluid that is inside the cell, which is intracellular. There is a fluid that's in between the cells, which is interstitial fluid. The one that is inside the blood vessel is the plasma, as you've seen, and they're distributed like that. So we're not going to look at the plasma, but we're going to look at mostly these interstitial fluids, which is available in those particular components, in those particular cavities that you've highlighted. Now, these body fluids can be analyzed to diagnose different conditions, such as hemorrhagic conditions, or to determine whether the hemorrhage is due to trauma or maybe due to some malignancy that is underway, or infectious diseases, inflammatory conditions, malignant processes within body cavities, and the central nervous system. They are not derived from the blood or urine, so they are not standard fluids that you may be able to expect. And they occupy the CNS, central nervous system, and the serous fluids occupy those areas, like the pericardial around the heart, then the pleural around the lungs, as I mentioned, and then peritoneal around the abdomen, and then synovial in the joints. Other fluids include the peritoneal dialysate that might be brought to you for analysis, and then peritoneal lavage, and then bronchoalveolar lavage as well. They can also be brought to you apart from the ordinary sputum for analysis. Now, how are you going to approach these fluids? Before we look into the details, we need to understand how they are collected and which containers they're supposed to be brought in. And we think that these fluids are supposed to be collected in dry containers, aseptically, meaning that without contamination, and traumatically, meaning that without injury to the cells that are surrounding that fluid, to avoid mixing with blood. Blood will become very problematic in diagnosis when you're looking at it, because the blood cells tend to occlude the ordinary microscopy. And they shield the cells of interest in that particular examination. So if you are looking at the blood sample, you might want to be very careful so that it's not going to occlude the cells that you're interested in. The tubes that are used are like for biochemical. Mostly we use fluoride, but other containers can be used depending on which chemistry you're looking at. Fluoride will be used for those tests that require to be stabilized, where no metabolism is going to take place, such as glucose, such as adenosine deaminase, such as lactate dehydrogenase. Those analytes that are prone to metabolism, very fast metabolism, especially when they're kept outside the 2 to 8 degrees C. So fluoride tubes are preferred in that case. Then we have microscopic examination, which collected in an EDTA tube, bacteriological exams in plain tubes that are sterile. And then we have cytological exams in plain tubes, or those 50 ml tubes. A fluid volume of above 20 can be examined, but preferably 50 mils and above is okay, in order for it to be possible to get enough cellular materials for examination after spinning. Now, after getting your fluid, these are the approaches you're going to look at it grossly, macroscopically, and tell the color and such kinds of things. And then we're going to look at it with biochemical analysis. There is also microbiological analysis, and then microscopy. These ones are pretty standard, but on microscopy, I feel that's where a lot of differences might be able to arise. That's where maybe some competencies we need to develop so that we can be able to do a fluid microscopy very well in our labs like that. Now, grossly, we looking at generally all the fluids, and we think that CSF is clear and colorless, while serous fluids might be pale yellow and clear, like that. And if the specimen is bloody or blood-stained, then you have to assess where the hemorrhage is coming from, whether it's due to trauma because of the procedure itself or due to malignancies. You can be able to differentiate. Then orange color, of course, suggests that the presence of breakdown products of blood, such as maybe bilirubin. Then green color may be associated with meningitis or hyperbilirubinemia, too much bilirubin in blood. And then brown color is also associated with a hypermelanosis, or maybe too much melanin pigmentation. That is usually shed from malignant, malignant melanomas that are having melanin, too much melanin secretion, like that. Then cloudy or turbid specimens are associated with infection. or the presence of protein in fluid. So if you look at the fluid, yeah, of course, it's already pointing towards something. You look at the cloudy fluid, it's going to point towards some infection or high protein levels. So your differential is going to think towards that particular direction. You want to determine whether there is an infection in that fluid or if there is too much protein. Of course, now we have to correlate with the serum protein to see whether there's an abnormality in this fluid. And these are the colors as we've identified. So biochemical examination of body fluids include uh, such things such as albumin, protein or albumin levels, and the determination of serum ascites albumin gradient, which is just the difference between the serum ascites and the serum ascites, serum albumin and then ascitic albumin, which is supposed to be less than 1. Then it can be able to help us differentiate between what we call a transudate. This one should not confuse us, a transudate and an exudate, which we're going to define in the next few coming slides. What I needed to mention is that the fluids are different from the blood, where a lot of harmonization has been done in terms of reference values, in terms of the interpretative criteria for these fluids. But the fluid for the blood, but for the fluids, it's not so much done, not so much well done. You might not find very reliable reference values for a particular analyte, which is called the matrix effect of the fluids. That's why we need to correlate between the fluid analytes that you're getting and the serum analytes that you're getting, so that now you can tell, because there's supposed to exist some sort of homeostasis between the fluids and the blood, and differences in those particular components will be able to tell us whether there's an abnormality in the fluid or whether the fluid is actually normal. Then only fluid types indicated by the manufacturer or validated by the laboratory should be tested on routine chemistry analyzers. This is very important to note, that we have fluid protein levels, and we are also running serum protein levels. So we need to determine whether the analyzer that we're using or the kits that we're using have the protein that is have the protein analysis that is also validated for other fluids, which is usually going to be indicated in the manufacturer kit inserts, so that you may not end up now measuring protein levels on a platform that only does the protein level for the blood, and you're using now the ascites or something like that, because we need to have reliable results. Then SAG is, of course, the difference, not the ratio, but the difference. And it is supposed to, if it's above 1, then this is a transudate. If it is less than 1, then this is an exudate. And exudates are usually pathological, which means that now the ascites is having more albumin than the blood. And because the albumin is osmotically active, it will tend to pull the fluid towards it, which will then end up in effusions now in those particular cavities. You can also do a glucose test in fluoride tubes, and in decrease in glucose will indicate bacterial infections and malignancy. So you need to bear those ones in mind as you do your analysis. Then adenosine deaminase for extrapulmonary tuberculosis, which is usually elevated in extrapulmonary TB. If you do your ZN and maybe you're not seeing any bacilli, this fast bacilli, you may do an adenosine deaminase, and it will be able to pick, maybe because the fluid is not adequate or something. So ADA would help in arriving at a diagnosis like that. Then LDH ratio, which is supposed to be less or equal to 0.6 for pleural and pericardial fluids. So SAG is only applicable for peritoneal fluid because it is ascites, serum ascites albumin gradient. But these others, we may tell whether it's an exudate or a transudate using the LDH ratio. Then high amylase levels will indicate the presence of pancreatitis. Now, on microbiological exams, we only do this if we expect suspecting an infectious disease, and body fluids can be cultured or subjected to molecular tests. Nowadays, people don't do, most labs are equipped with molecular assays that can be able to detect pathogens directly from the primary fluids. So they are able to do molecular sequencing and they can do diagnostics within the same day. And others are still doing the culture. So depending on the platform or the environment that you are in, you can either do cultures or do molecular assays for specific infectious diseases. Then for microbiological testing, the body fluid is added to a culture medium immediately. If this is not possible, then you can be able to keep in the fridge or maintain a temperature of 2 to 8 in transit towards the microbiology laboratory. Then molecular testing is robust in nature and quick turnaround time, and it's usually preferred nowadays, now that most people are having molecular platforms. All right, and then now on the cellular counts, this one identifies and quantifies the total nucleated red cells, or TNCC, which include the leukocytes, the erythrocytes, and non-hematopoietic cells. I've included NRBCs are nucleated RBCs, which are part of the nucleated cells. So you can be able to count these ones and see them in a differential in your fluid. They are performed manually by specialized test systems or by using automated platforms. And the reference method, of course, because of so many variations that may be able to exist in specialized tests and automated tests, the manual method is considered the reference method for these fluid counts, because through the manual process, you can be able to pick out errors that might not have been picked by the equipment, and you can be able to correct those errors as you report. Now, a hemocytometer is a counting chamber that consists of microscopic slide with a grid etched onto the surface. They include the Nuba chamber that we have seen, which is common, the Fritz Rosenthal chamber, and then the Baca platforms. Those are some of the ones that are used for cell counting, but in our environment, in our locations, the Nuba chamber is mostly used. And if the body fluid is sample is clear, it's not necessary to make a dilution before counting on hemocytometer. The clear fluids, if you dilute, you'll make the cellular material even more diverse, widely dispersed. So you may not want to dilute those ones. You analyze them directly. But if there are too much, there is so many or hypercellularity in that fluid, you might want to dilute with the relevant diluents to ensure that you can be able to singly see these cells and count them comfortably on a hemocytometer, just as it's applicable in the semen analysis. If there are too many semen, if there are too many spermatozoa in the semen sample, you might want to dilute or using a specific standard ratio, so that now you may consider that ratio as you do your final quantification of these cells in those body fluids. A dilution may be necessary for turbid fluids, as I've indicated that. I know this one we have seen, but I just wanted to highlight the Nuba chamber, which is used commonly for cell counts, and it is here where there are these squares, the grids. First one, usually 9 in number, And these grids are also subdivided. As you can see, one grid is 1 millimeter, 1 millimeter by 1 millimeter, and then by 0.1 down, like that. So the depth is usually 0.1 millimeter. So you consider these values while you're doing your calculations and estimating the number of cells per volume of the fluid. Yeah. Now that is where you may get a count of maybe say 500 cells in 1 microliter of this particular fluid, just because of using these particular volumes to arrive at that particular calculation. And it is the only way that you can be able to tell whether this fluid is having normal cellularity or it is having too many cells. And you can now tell, associate those hypercellularity with the conditions that they are associated with. Yeah, if you're looking at the lymphocytes, you're looking at the granulocytes, you're looking at the macrophages, the monocytes in tissues are actually macrophages. You may also see them here at power 40, and then you can be able to count them. As we keep looking at that, for comfortable counting, when you want to do a manual differential for these fluids, especially after ascertaining that on the Nuber chamber, you've seen that there are so many cells. You might want to do a differential now using a higher power, because that one can only take you to up to power 40. Now you can go up to power 100, and then now do the differential count of the total nucleated cells. Yeah. So this one is based on the hemocytometer count. Then a suggested number of drops of the body fluid can be added to the cytofunnel and placed in a centrifuge, a cytocentrifuge, and spun. After getting the deposit, then you can be able to stain, yeah, using the relevant stains. Most commonly used is GEMSA, Wright's GEMSA. And then other people will also do Papa Nicola stain, which is special for those other guys who can be able to report it. But I'm going to concentrate on gem sustained deposit. Now, after doing your cell count, you may do a differential up to 100 if you can be able to count up to 100 cells. Sometimes it's not possible to reach 100 cells. If you have reached 70, you've counted 50 neutrophils, you've counted 20 lymphocytes, you've not counted any other thing, and you've reached 70 and there is no other, field that you can count, you just use the number that you've reached to record the results as they are. So if you have managed to reach 100 cells, use the differential as it usually is. If you count fewer cells than 100, then you record what you have achieved at the highest count. Now, hematopoietic cells that are observed in body fluids include segmented neutrophils. Now, by now, I hope that we know how a neutrophil looks like. We can also expect to see lymphocytes. Very nice. These ones are multilobulated. Neutrophils usually have between 3 to 5 lobes, and lymphocytes have only one lobe on the nucleus. Monocytes, their nucleus look like a bean, like a kidney. So, and they have some vacuoles, so you can also check and see them there. Eosinophils are eosinophilic, is it pinkish? Yeah. The orange eosinophilic pigment that you'll be able to see in the cytoplasm through the granulation. You'll be able to differentiate the eosinophils now between those and the basophils, which usually have the blue granules in their cytoplasm, like that. So you look at those cells, count them, then record their percentages. Also, as you look at these cells, you can, in your manual differential count, you can also see bacteria in fluids. You can see yeast, you can see fungi, you can see parasites. which might be the cause of the problem to these patients. Sometimes people think about very big things like cancer, like what, and then you may just realize there's a fungal infection in the abdomen causing ascites. So you find that when you report it, you've done, you've saved that patient against so many other following diagnostic modalities and costs. They could also be parasites. So you also check on the presence of the parasites, over cysts, and all those forms of parasites. Um, Cell count is usually 0 to 5 per microliter in adults. Neonates is more, right? Then there is the mononuclear cells, which are lymphocytes and monocytes. They have one nucleus. These ones are kidney shaped. These ones are round. And this is the normal range for adults and in children. And then monocytes, 15 to 45. This is in your manual differential count. Now, if you find anything that's above 80 for adults, it now becomes a problem for lymphocytes. Monocytes that are above 45 might indicate an infection. Neutrophils are supposed to be 0 to 6. Anything above that is a problem. Eosinophils are rare, and then ependymal cells are very rare. RBCs are not normally present in a CSF fluid. And this one has been adopted from this guy over here, 2015. Now, the centrifuge specimen is centrifuged to concentrate the cellular components, and the segment that contains the cells is fixed with methanol and then directly applied to the slide and stain for those guys who want to do the Papa Nicola stain. And also, you can make a block, just like we do in histology. You can also make a cell block of those cellular materials and stain with H&E. Especially if you anticipate to do immunohistochemistry and those kinds of auxiliary tests on it, you may prepare a block. And then immunocytochemical stains can also be applied to these sections. And then cell blocks are also usually performed to confirm the presence of malignancy. So blocks will be able to concentrate a lot of cells. This one is for the guys who are in the other practice in cytology. Now, going to individual fluids, synovial fluid is found between movable joints. These joints include knee, elbow, wrist. So the doctors can get this fluid from any of these joints, then submit it to you for analysis. The process through which they get these samples through arthrocentesis, piercing through the joint and then obtaining some fluid. Then this synovial fluid is lined with synovial membranes that have synoviocytes, which we need to see how they look like. The phagocytose absorbs, secrete, and synthesize hyaluronan. This one is also involved in the synthesis of hyaluronic acid that is primarily present in synovial fluids. They lubricate joints, transport nutrients and wells from the joints into the bloodstream now for elimination elsewhere. Now, conditions that can be diagnosed through synovial fluids include such things as non-inflammatory disorders, inflammatory disorders, septic disorders, crystal-associated arthropathies, or hemorrhagic arthropathies. So non-inflammatory, this one will find normocellular fluids, but they might have crystals. Inflammatory usually have increased cellular numbers. Septic will have increased neutrophils and those macrophages. Yeah, they will indicate that this is an infected synovial fluid. Crystals, as I've described here, you'll be able to expect to find some crystals in the fluid that you're analyzing, the synovial fluid, which is very important for those guys that are suspected to have joint issues such as gout. So this one is usually done using polarized light microscope They are very nice. If you have seen a polarized light microscope in your environment, they can be able to be used to observe for these crystals here. There are usually three that can be observed. There is monosodium urate that is observed in gout. So you see these crystals, you're going to conclude that this patient is having gout arthritis now. You see the calcium pyrophosphate, CPPD crystals, this patient is having pseudo gout. It's not true gout. So treatment for gout will not work in this case here. So if you differentiate these two here, you'll have helped the patient really so much to go and get the right treatment. Then cholesterol crystals are also present in rheumatic disease. So if you see them, you're going to correlate them as such. Then synovial fluid is analyzed for white cell counts, and the differential include those ones here. I just want us to know how they look like. Have some pictures in this presentation that we're going to see, and it's going to help us maybe do this microscopy in practice as we look at them later. So the crystals will look like this under the microscope. These needle-like sharp crystals are the monosodium urates that are present in gout arthritis. These ones here. So you pop in there, you see a slide. You're going to see these crystals, and then you're going to conclude that this is a gout. Patient is suffering from gout. These rhomboid crystals, these ones here, are the calcium pyrophosphates, which are seen in pseudogout. Then cholesterol crystals here are seen in rheumatic disease. So those are some of the morphologies that you might expect to see in on a synovial fluid. Apart from that, of course, there is also microbiological. We can do a gram stain if you are suspecting an infection. Gram stain of the primary fluid. You can observe for gram-positive or gram-negative organisms and report their presence. There's a group of serous fluids that I had grouped together, which are usually three, and we are going to discuss them separately. But just as an introduction, these are serous body fluids are secreted by serous membrane that line the body cavities, and they include these membranes are either parietal or the outer membrane, and then the visceral or the inner membrane that surrounds those particular internal organs. They are named according to where they are found. So like pleural around the lungs, cardiac around the heart, abdominal organs, that's peritoneal. Both of these membranes are lined by a single layer of mesothelial cells or mesothelium, and the space in between contains a small amount of serous fluid. That's usually 1 to 10 mils. Anything above that might be an effusion now. Then excess serous fluids lead to effusions, which are either transudates or exudates, and we have described these ones. Transudates is a physiological, more or less not associated with inflammation and cancers. But exudates, if you determine that the fluid is an exudate, we need to really be very careful and come up with why it's an exudate, because there is usually a reason why. It's either an infection, a malignancy, or something like that. So you can help the guys just after determining that it's an exudate, you can also help determining why that exudate is there, and it will be a conclusive fluid analysis. Now, all right. Transudates have low protein and cell concentration and indicate systemic disease. And exudates are associated with localized inflammatory or infectious conditions or neoplasms, right? And they have high concentrations of those analytes that we intend to expect to find. So those are the things that we can be able to find. And when we do the biochemistry, it can be able to help us differentiate those two. Now, these are the characteristics of the two fluids. Transudates over here, the exudates over here. As you can see, transudates are usually like physiological, mostly arising because of an imbalance in the physiology of these membranes, either because of a congestive cardiac issue, either because of a renal issue that is leading to imbalanced water, homeostasis in the body, which are usually clear and pale yellow. But these are, the exudates are very bad. They are usually cloudy, turbid, purulent, and blood-stained or bloody. And the SG for this one is usually less than 1.015, above 1.05. The fluid serum protein ratio is less than 0.5. These ones are usually more than 0.5. LDH ratio less than 0.6, more than 0.6. WBC less than 1,000 per microliter of fluid. And then these are more than 1,000. You can only determine this when you've done a manual differential count. Then total protein of less than 3. These ones are more than 3. Now, individual fluids include the pleural fluid. Now we are going to look at the individual fluids located between the parietal membrane lining the chest wall and the visceral membranes surrounding the lungs. Anatomically, we revisit the anatomy classes. In normal adults, it's approximately 10 mils, and it's produced daily by the mesothelial cells. And we've seen that these cells are found in this membrane that's lining these particular cavities. So they're just normal, like epithelial cells in those particular layers. In specific disease states, the fluid can accumulate, of course, and lead to an effusion. Transulates can be due to increased hydrostatic pressure, forcing fluid across the membrane, via those transport mechanisms, as seen in congestive heart failure or due to decreased oncotic pressure associated with hypoproteinemia in renal failure, like that. So water imbalance translates. Exudates are bad, localized inflammation and infection, which will include pruritus and pneumonia, or pneumonia infection, malignancies which damage the pleural lining and impair filtration process. So the normal physiological process of filtering these fluids is impaired. You'll have the exudates. Then the fluid is collected by the procedure called thoracocentesis for pleural. And this is the procedure, which I'm not going to belabor on it. And the fluid is drained and collected by a syringe and allocated into tubes containing EDTA for cell counts and heparin for additional studies that might be anticipated. If you want to do a microbiology, you collect in a sterile container, you can do your microbiological workup. This is what we're saying, that the pleural fluid is found surrounding the lungs, both the right and the left lung. You can see this yellow coloration, and it is usually drained by thoracocentesis, which is the procedure here, put in those containers. And this one is a transudate, very nice, in an append tube. Oh no, in a centrifuge tube. And this one is an exudate. They're very different. So you find this fluid here is a transudate, a normal one, and this is an exudate, and you can work on them like that. Cell types encountered, depleted cells are between this and this per microliter when you've counted. They are mostly macrophages. Macrophages are, monocytes in tissues. Then lymphocytes in these percentages. And neutrophils can also be found. If there are too many, then they're increased in bacterial infections. Then also we have mesothelial cells, because just as like the epithelial cells that we see in urine, in HVS, these epithelial cells are also shared in those cavities. So you may find to see few mesothelial cells in those cavities. We will look at some few cases of that we can be able to see. These ones are stained by GEMSA. So you look at the fluid is stained with the GEMSA, and you can be able to look at it. Very beautiful images, and they're very nice when you look at them under the microscope. So gross appearance, we have clear straw. This one, further analysis is usually not necessary because these are transudate. But cloudy, these are exudates, which will increase infections or empyema. Red tinge is no traumatic type, then malignancy or pulmonary infarction or trauma. green, white, or turbid, rheumatoid and pleuritis, milky white or yellow, the chylous effusions, rich in those fats and lymphatic fluid or the lymph, milk or green metallic sheen, chylous or chyliform effusions, viscous or hemorrhagic in mesotheliomas, chocolate color in ruptured or amoebic liver disease. Now, if you do a microscopy, you can see these ones here. This number 2 here is this lymphocyte. It's only one lobed. And then this one is a monocyte, looks like a kidney thing. These are neutrophils. All these are neutrophils. Then you can see these ones here. All these small ones are lymphocytes. Then these are mesothelial cells. Mesothelial cells are large, they're very big. They're bigger than neutrophils, even up to 2 times the size of neutrophils, or even more. So they look like this. Have one nucleus, which is almost eccentric, but not touching the surface of the cell membrane. Yeah, they usually leave a space. They could be having 2 nucleus or one, and some vacuolation in the cytoplasm. This one's a malignant cell. I'm not describing that one. And these are also mesothelial cells, very large. Yeah, but the nucleus doesn't touch the periphery of the cell. You can see that. Yeah. Okay. Peritoneal fluid present inside the peritoneal sac, and they're obtained through paracentesis, and serves as lubricant. They're not supposed to be, the fluid is not supposed to be more than 50 mils. If it does go beyond that, it leads to ascites or effusion, pleural effusion, also called ascites. Then common causes of translate effusions include heart failure, cirrhosis, hypoalbuminemia, which we'll discuss as well. So you see these guys walking around with ascites. Yeah, it's not very complicated. Let them obtain these fluids and bring them to you. You can help find the causes of these problems and help them actually get the right treatment from your labs. Now, exudative effusions are associated with infections like bacterial, tubercular, fungal, or parasitic, neoplastic diseases like hepatocellular carcinoma, mesothelioma, lymphoma, and other gastrointestinal diseases like pancreatitis and bile peritonitis. Reference values are also highlighted there, which I'll not be able to discuss further, but we shall be able to see it in the presentation. Now, on the pericardial fluid, this one is around the heart, and it lubricates and reduces friction when the heart is pumping. Translates, of course, observed in hypoproteinemia and increased in hydrostatic pressure of the circulatory system. Exudates are associated with infection, inflammatory condition, and malignancy. Bleeding disorders and trauma may result in accumulation of blood in pericardial space, resulting in more hemopericardium. So you can see hemopericardium and then conclude that you can see the blood, and then you can be able to mean that it's just a hemopericardium or malignancy. Then inflammatory conditions like post-cardiac injury syndrome, in myocardial infarction, systemic autoimmune diseases such as lupus or rheumatoid arthritis, and radiation therapy. So you see inflammatory changes. Malignancy like mesotheliomas or metastatic tumors from other secondaries. This means that they are coming from elsewhere and bringing them like that. Then collection is via pericardiocentesis through the 5th and the 6th intercostal space that anatomically you can also be able to tell what the conduct is. We're going to look at some pictures because chemistry, you can be able to do it. You can be able to see how the reference values. Even microbiology, you can look at it. But even the gram stain is very important. We're going to look at some of the images of the gram stains that can be able to help us really find the diagnosis. And morphological features of helpful in distinguishing mesothelial cells from other cells I may not be able to be labeled on this, but just know that there is mesothelial cells, and there could be adenocarcinomas, which are cancer cells from elsewhere. That if you are interested, you can be able to look at this table later on. But those guys in clinical labs, you can maybe just leave it alone. Then these are the morphologies that anyone can see. Now we are saying that mesothelial cells are commonly found, and these are mesothelial cells. They are like lymphocytes, but they're very big, very big. You look at them, you'll be able to conclude this. If you compare with the lymphocytes, these are lymphocytes, and these are mesothelial cells. So you can tell them apart. And in the background, we have the red cells. These are red cells. These are red cells. This one's here. But because this is a deposit, this sample was centrifuged first. So you may not be able to see very good shapes of RBCs because they are destroyed in the process of sample preparation. Then mesothelial cells, of course, they can also look like that, varying sizes, but this is the morphology. All these ones. The same here. And then they are blebbed. In inflammatory condition, you'll see these blebs. They look very beautiful, right? These ones here. They usually have microvilli on their cell membrane, but when they absorb water, just like a balloon, they'll balloon up. Like you see these blebs here, these sorts of blebs. You can see the blebs on the side, the cell membrane. This mesothelial cell has absorbed some fluid and it has bulged up, just like a balloon. So you can be able to see this one, and it is, means that there is an inflammatory process that's going on, which is leading to the absorption of those fluids. This one has very good RBCs in the background. You can see these ones. And this one is not an mesothelial cell. This one here is a macrophage. Yeah, monocytes that are actually in the peripheral fluid is a macrophage, a plant. And then macrophages and the mesothelial cells. You can see this one here. These are macrophages. These are macrophages. These are also macrophages, but mesothelial cells, very few, but most of these are macrophages. Most of them are macrophages because they lack morphology that you can be able to see in mesothelial cells. Then this is a mesothelial cell, and these are others are macrophages. Now you can see the difference. So you see the macrophages, you'll know that this is an infection. You see many mesothelial cells, you'll see that this is hyper, the lining of those membranes are shedding too much, which might include a malignancy or another inflammatory process. Signet ring, you can see this ring here. That is a population that has pushed this nucleus just to the periphery of the cell. You see a signet cell like this one here. This is a macrophage. This is a signet ring. These ones are very important. They might indicate other things, and like gastrointestinal tumors, and you may observe signet kind of cells in the peritoneal fluid. So you see those ones, you might want to do further analysis to arrive at a conclusion. Then there is phagocytosis. Yeah, this one is a macrophage. Macrophages phagocytose, right? They phagocytose bacteria, they phagocytose what? Debris. So they are now phagocytosing these red blood cells. And you can see their red blood cells are within their cytoplasm. They are doing their macrocytic work of phagocytosing. So you may also see them. And this probably means that this is a chronic hemorrhage that has been there for a while. And this patient is having this particular presentation of morphological, that is, you can see that. Further morphological appearances, these are lymphocytes. Just as they appear in the peripheral blood, these are lymphocytes. Very nice, very round, very small. They are almost compared to red blood cells. That's why we can tell that this is a microcytic cell or a nomocytic cell. We compare it to a small lymphocyte, and you can see they almost appear the same. The nucleus, I mean, you compare the red cell and the nucleus of this small lymphocyte. So this one can be able to differ. help you differentiate whether it's a macro, not a macrophage, but a mesothelial cell or a lymphocyte. But you can see these ones are just lymphocytes. For those guys who have done some thing on hematopoiesis, you may see that this is a blast, which is an immature cell that is in circulation, not in circulation, that is in this fluid. This is a neutrophil, a lymphocyte over here, but this is a blast. This is a blast. Then this one here is a reactive lymphocyte, which is a plasma cell. Plasma cells are commonly found in the fluids because they are secreting antibodies to fight against infections in those areas. So if you see these kinds of morphologies, these ones here, they are plasma cells, which are good, very good, because they are helping the body secrete antibodies to help fight the infections. There's another immunoblast here, which is an immature cell that is having very big nucleus and irregular cytoplasm, irregular membranes with many nucleoli. You can see inside there, you can see some dark blue stuff. Those are nucleoli. And they're very important to delineate whether this is a mature cell or it's an immature cell. So you can see inside there, you see them there. I think this is the second last one on morphologies. And this is these ones now are put together the lymphocyte and the mesothelial cell so that you can see the difference. This one is a mesothelial cell, this one's a mesothelial cells, and the rest are lymphocytes. The rest are lymphocytes. So you can be able to look at them on the same slide and differentiate. Now this one here is an inflammatory process, an acute inflammatory process because of so many neutrophils. You can see these ones here. So many neutrophils. Usually when you see a picture like this, it only means one thing, a bacterial infection. So you see your fluid and you stain it with your GEMSA and you're seeing this kind of a picture, you're just going to conclude that it's an infectious process. Maybe pneumonia if it is a plural, maybe spontaneous bacterial peritonitis if it is the ascites fluid that you're looking at. Then you can also see these organisms here. These are bacteria inside a polymorphonuclear cell. Yeah, this bacteria here, they've been engulfed because they are present in those fluids. And you can also conclude that these are bacterial infection. So this patient can be covered on antibiotics like that. These are cocci, all right? They are round, but they are also phagocytosed within the cytoplasm of this polymorphonuclear cell that is almost dying off. You can see this cell is becoming a pus cell. It's dying off. And it's containing a lot of a lot of cocci, which are also spread all over here in free fluid. So you see those ones, you conclude this is a cocci that's causing pneumonia or any other condition. Gram-positive organisms are here, which are usually cocci. Gram-negative organisms are here, which are usually what? Rods. And these are actually rods. You can see them there like that. So they will be present. And when you see an infectious organism, you will also expect to see a lot of neutrophils. They go hand in hand. You can see this background here, a lot of neutrophils in the background, and there are bacteria there. So this is a gram stain. This is just a plain fluid. And you look at it, you put on the microscope, you see a parasite like this one here. You conclude, you give a diagnosis right away, and the patients are going to be very happy getting antiparasitic treatment instead of thinking it is cancer and waiting so long to find nothing. Then these are eosinophils, or what do we call, in inflammatory conditions, in allergies. A lot of allergic conditions might lead to kind of this eosinophilia pouring out into the fluids, especially people who are allergic to some things like pollen. They're allergic to cold. The body secretes a lot of eosinophils, and you'll be able to see them in the pleural fluids, yeah, causing those kinds of asthma and everything. So the last fluid that I'm going to handle is on CSF. And then this one is found in the brain and the spinal cord cushions. And CSF is produced by the choroid plexus, as well as the ependymal cells, which also produce the ventricles in the ventricles, which also produce CSF. So it's producing the choroid plexus and the ventricles in the brain. It's produced at a rate of 20 to 27 mils per hour in adults, and the total volume is 90 to 155 mils. So you draw too much, it will cause problems. And if it's also too much, it will cause problems in the CNS. And it protects the brain and the spinal cord from and serves by serving as a cushion, providing nutrients and removing waste products. Analysis, it's obtained via lumbar puncture or a spinal tap between lumbar 3 to lumbar 4 or lumbar 5 to lumbar 6. And the indications is when there is infection, like CRAG, Cryptococcus meningitis, that's the most common one. Then hemorrhage, subarachnoid hemorrhage, and then malignancy, and then demyelinating disease. 10 to 10 to 20 mils are aspirated and put in several tubes for different analyses like that. The normal CSF is clear and colorless, and a cloudy sample will indicate the presence of an infection, protein, or lipids on increased number of cells. A sample that's bloody may indicate a traumatic tub or subarachnoid hemorrhage or SAR. Then size are fatal and must be differentiated from a traumatic tap. So you should be able to know that this is a traumatic tap or it's because of hemorrhage. Where in those guys who are having SAR, subarachnoid hemorrhage, you'll find there are a lot of deposition of iron in those macrophages. So you'll see black kind of deposits in macrophages. And then in traumatic taps, you'll only see RBCs in the background of the slide. So you will differentiate them like that. Then in traumatic tap also, there is progressive clearing of the samples from tube 1 to 4 that have been collected. And any bloody stain, blood stain fluid, you should be able to suspect SAR. Then there is no clot formation in CSF. So if it's present, then it is associated with the SAR as well. Then xanthoma or yellowing of CSF includes subarachnoid hemorrhage, which means that there is too much bilirubin in CSF. Now, pleocytosis means that there is increased WBC in CSF, which might mean that there is an infection or hematological malignancy. Some of the cells here, like this is a lymphocyte, and then we have another lymphocyte over here. Then we have a monocyte or macrophages. They are not very good. They don't look very, very nice, the macrophages. And then we have the neutrophils over here. You can see them here. Then the red cells in the background. Then these ones are the choroid cells or the ependymal cells. This one's here, which you may not expect to find so much unless it is a SAR. Then we have these ones here are lymphoma cells. This one's PAP stained, so you might not be able to appreciate the nucleus very well. I'm not going to belabor on it. These are malignant cells. They don't resemble any morphologies we've described. So anything that's not a lymphocyte, not a macrophage, not an mesothelial cell, not what, it might just mean that it's a cancer cell that has come from other places and now it's present in the CSF. Then we have these ones here. These ones are organisms, the Cryptococcus organism. You can see that they are clearing over here, they're clearing here. They have been ingested by this neutrophil here. Cryptococcal organism, you usually say, if you're using India ink, you just stain the background. They don't pick the color. You just stain the background and then you observe the organism. So in this case, the organism doesn't stain, but you'll just see clearing inside the neutrophil, and you'll conclude that this is a cryptococcal infection. Then these ones look like fungi. There are fungi also that are present in the CSF. So 7D is intracellular fungi. This one's here. Peritoneal dialysate, I think this is something that can also be presented to you, mainly for microbiology. I will not be able to handle so much on that, or as well as peritoneal lavage, washing of the peritoneum, and then bring a sample to you for the same exam, usually for microbiology. That one cannot be used for cell counts. because washing interferes with the cellular numbers. So you can only do microbiological workup there. Then bronchoalveolar lavage, this is the last thing I'm handling, and it is the procedure that removes cells lining the mucosal surface from any non-adherent cells in the bronchoalveolar system by rinsing with a sterile saline solution. And these are results from introduction and removal of warm saline into the lungs via bronchoscope, usually under general anesthesia, because this is an invasive procedure. Then it's indicated for interstitial infiltrations such as sarcoidosis, alveolar infiltration like in pneumonia of unknown origin, pulmonary infiltrates seen in immunocompromised patients, especially how you'll be able to see fungi in these patients. Then occupational dust exposure such as asbestos-related disorders, silicosis, and coal workers pneumonia. Those morphologists will be able to see them. Analysis include cell and differential count, where you count the nucleated cells in health, and they range between 100 to 400 microliters in healthy individuals. And a majority of those are macrophages, and we've seen how the macrophages look. So the presence of other hematopoietic cells such as lymphocytes is considered a contaminant because of the procedure. Yeah. And then non-hematopoietic cells observed in bowel fluid are mainly pneumocytes and ciliated epithelial lining cells, which are mesothelial cells. And common bacteria, you can also see bacteria, and yes, because of the airborne organisms. So that was it, I think, from this side. And those are the references that I used for this particular presentation. I just want to highlight that this guys here, this one here is a medical laboratory scientist, I think, writing workups for those guys who are doing the American Society of Clinical Pathology certifications. And all these things that I've highlighted in these slides are highlighted in this particular book here. So that now it means that we can be able to do it. It's not meant for other people or some other guys from wherever, but it is our role that we're able to pick it up and do these microscopies and help our patients get the right treatment at the right time, which is usually my main goal of these particular presentations. So thank you so much for giving me this chance. And now I hand over the mantle back to Sally for finishing up, maybe for inputs, questions, or any other clarifications. Thank you so much.
Thank you. Thank you so much, Baraza. Members, if you have been, if you want to appreciate Baraza, there's that icon on your screen, the icon that says react. The icon that says react, when you point at it, you open it, you can clap, you can send flowers, you can send all the reactions that you want to Baraza, just to appreciate him for the informative presentation that he's given us this evening. Keep doing that. Thank you. Thank you, Cosmas. We have some few questions for you here, but just going through the chat section, you can see that it's been a good and an informative presentation. We really appreciate you. Thank you so much. People are grateful that you've presented and you've done your slides very well, and they were audible. I picked a question there before I move to the Q&A. There was a question there, and most of us are asking about the slides. Kindly interact with our YouTube channel. You'll get all the presentations that have ever been presented here, and even this one, you will get it there. So if you need to read some more, you need to revise some more, kindly interact with our YouTube channel. There's now to the questions. There's Benson Lusenaka. Benson Lusenaka asked, what's the function of platelets in the body? So that's the first question Baraza would like you to tackle.
Okay, platelets they help in the process of blood clotting, and stop hemorrhage or maybe bleeding when someone has been cut or they have undergone some trauma. Yeah.
Thank you. Thank you, Baraza. Now to the Q&A session. I have some few questions also there for you. And Joseph Joshua says, hello, is adenosine diaminase specific to detecting extrapulmonary TB? Is adenosine, okay, take it up. Thank you.
Okay. Yeah. It's not specific. That's why there is ZN and other diagnostic modalities that are very specific for TB, but it is supportive. It is supportive, and it can be able to help you to, if you have done a biochemical analysis and you're seeing high ADA levels, then you might want to look at ZN to help you conclude that this is because of TB, because it could be elevated in other infectious processes as well. Thank you.
Thank you. Thank you, Baraza. The other question is from Wilfred Moriasi. Wilfred Moriasi asks, when you lumbar puncture, will not have a backflow of blood to the spinal cord and cause trauma or infection. So I think what I'm getting here is asking, when you do lumbar puncture, will you not have a backflow of blood to the spinal cord and cause trauma or infection? Back to you, Baraza.
Those are complications. No procedure is 100%, shielded from errors. So you might have a lumbar puncture that is hemorrhagic, but you now want to differentiate between whether it is because the blood is now because of the trauma or it's because of the pathology that's affecting the CSF. So the procedures are not 100% safe or shielded from errors such as accidental hitting of a blood vessel, which might lead to bleeding inside the CSF. Yeah, so maybe that's basically it.
Thank you, Baraza. Thank you. Also, Christopher Mugambi Isaac. Christopher Mugambi Isaac asks, how do we diagnose hormonal imbalance in cardiac fluid?
Pardon the question.
How do we diagnose hormonal imbalance in cardiac fluid?
Hormonal imbalance in cardiac fluid. I really don't get that question very well. I don't know which hormones the person asking is thinking about, but I may not. It's maybe I have to look at it whether it's possible, but I have not seen that one in the literature. Maybe I have to check on it.
Okay, thank you. Anonymous attendee, he asks, in the case where you don't have a biochemistry machine, is it advisable to test with a urine strip for various parameters of importance?
Okay, urine strips is only applicable to urine analysis, but maybe the pH can be determined via the use of that pH section on the urine strip. Maybe that is the only thing that can be done. But other parameters are validated for the urine sample. So you will not use a urine strip for protein estimation in other fluids, because I have not seen a validation for those ones, unless maybe you've done a validation in your setup for urine strip use in those fluids. It's allowed like that. So if you do a validation in your lab for that particular key strip, then you can use it. But if it's not been validated, don't tempt that one, because you might release erroneous reports to your clients.
Thank you, Baraza. Thank you for your time. That's all the questions that we have. I hope I'm not closing anyone out. Anyone still has a question to raise? Thank you. Thank you, everyone, for being here this evening. Thank you so much, Baraza, for taking your time to prepare and even to present for us this educative and informative presentation on fluid analysis, body fluid analysis. We really appreciate, and we appreciate every attendance, every member that attended today, and LMSK for organizing this for us this evening. We urge you to inform your colleagues and friends and other members and everyone that you know to join us up next time, Wednesday, and the next webinar is on Wednesday, the same time, 3 to 4:30, and Fridays. So we have them Monday, Wednesdays, and Friday. You are highly welcome. Kindly inform your colleagues to come so that we may line together and get this knowledge that is here together. We really appreciate all of you for coming, and we appreciate the organizers even for this. Maybe before we'll as we do this, I will just allow Baraza to give us his parting shot, even as we finish up on this. Baraza, I'm giving you just a minute to give us your parting shot, even as we finish up on this, kindly.
Okay, Nelly, thank you so much again. It's always a pleasure to be here. And mine is usually to encourage everyone to pick up their positions very well in those labs that we are working. There is so much that we can be able to do in our labs. So a lot of things that we can be able to help guide treatments, guide decisions. And these presentations are just meant to enable us to stand up strong in our fields, to ensure that we are visible in the healthcare team, that we are actually contributing significantly towards patient management. And that's all. So as we learn like this, let us put it in practice, because the things that we're talking about are usually found in any lab that's accredited to work in this particular nation. So thank you so much again for having me, and I wish everyone a good evening.
Thank you. Thank you, guys. Thank you, Baraza. Thank you, LMSK. And thank you, everyone that was here for this webinar this evening. See you in our next webinar. That is Wednesday. Good evening.
Good evening to you.